we enter the world of work and clinical practice and clinical reasoning and everything.
Yeah, right. Like, turns out it's nice to take a break. That's how I feel with every holiday. I'm like, oh yeah, this is nice.
Yes, yes. And it takes some time to like sink into being off. And then once I'm there, I'm like, okay, this is
Yeah,
nice. So
yeah,
feeling good.
yeah. I was like reading book for pleasure. I'm like, wow, this is so fun. uh, so I hope everybody else, if you're celebrating, have time off, you had a good one too. Rob, do you want to? I know people are familiar with you, but do you want to reintroduce yourself to the VMR community?
Oh, sure. I don't know if people are that familiar, but I'm Rob. I'm a second year endocrinology fellow. I went to UCSF for residency, where Sharmin and Jack were both my chiefs at one point, and I'm excited to present this case.
Thank you so much for being here, Rob. You're in my mind, you're famous, so
Oh,
everyone should know who you are. Thank you for being here. So if we can get the board up, we can get started. And thank you so much to Gia and Hansu for doing scribing and teaching points. All right, Rob, get us started.
either way. Okay. So this is a case of a 75-year-old woman who presents to urgent care with a chief concern of insomnia and confusion. And I'll give you the up till the physical exam. So the history was given initially by a family member who helps care for the patient and came to urgent care with them. And they said that before 2 months ago, the patient was in their normal, healthy state of being. But then over the past 2 months, she's had decreased energy, difficulty staying asleep because of urination. She's urinating 5 times a night, and she just can't stop drinking water. She's lost 10 pounds. She has no abdominal pain, but she's not eating very much because she has nausea. And she has a burning sensation in her feet, but no complaints to the family member of pain, dysuria, and specifically no flank pain. For past medical history, just high blood pressure, hypertension. She's had 3 pregnancies without complications. She has no allergies. She takes a multivitamin, specifically Centrum Silver, and losartan and metoprolol. None of these are new medications. She's been on all of them for years. And there are no other supplements or over-the-counter pills of any kind. Surgical history, none. Social history, lives at home, cared for by this family member, originally from Korea, moved to Northern California in the 1980s, worked in manufacturing, and no diseases run in the family. And I'll stop there.
All right, a super interesting start here. I would say we have a chief concern that we see quite often here within the VMR setting in terms of confusion, and then another chief concern that maybe comes up less often than we think of, or than we may see in these types of cases, but certainly comes up a lot in day-to-day practice, which is the chief concern of insomnia, right? And so I think this is an opportunity for us to practice sort of how we think through or approach two discrete clinical problems, right? We can think about using one to filter through the other, right? Insomnia has a very, very long list of potential causes to it, right? Disruptions in sleep can be broken down into problems leading to challenges sort of commencing sleep, right? So there can be things that make people have delayed onset of sleep. That could be things like anxiety, or even more somatic concerns like individuals who may experience restless leg syndrome. There can be a variety of things that lead people to have difficulty maintaining their sleep, right? So these are individuals who may wake up frequently in the night, and we see this frequently with things like obstructive sleep apnea, or even some problems that can come up in cardiopulmonary disorders like Shane-Stokes breathing. And then people can have problems with they may be able to fall asleep, they may be able to stay asleep, but they wake up quite early in the morning and then aren't able to go back to sleep after that. And we can see this in some other mental health disorders, for example, depression and anxiety, right? So there's that is sort of a list of common ways to think about insomnia, but then there's a long, long list of other things that can do it. Individuals may be taking stimulants, for example, having too much caffeine or other medications like methylphenidate or amphetamines that can make sleep a problem. There can be a variety of other neurologic syndromes that can do it. And then sometimes individuals just may have too much sympathetic activity overall, right? Whether that's from stress or from other endogenous sources. So we have that very, very long list of things that can cause problems with insomnia, but we have a much narrower list of things in terms of individuals who may, in terms of the potential causes of encephalopathy. And we can fall back on our usual MIST framework for that, right? Metabolic problems, infectious problems, structural problems, and toxins. And if we start to filter those two things together, I think what becomes more of a focal point here is thinking about potential metabolic issues and potential toxins. More often than not, infections, when they cause encephalopathy, usually lead to decreased arousal rather than hyperarousal. The same thing goes for structural problems, right? A new seizure focus, a stroke, or a bleed. Individuals tend to, more often than not, be somnolent and sleepy rather than having insomnia and being maybe more hyperactive and hyperaroused, right? Even many of the metabolic problems, right? Things like hyponatremia, liver function abnormalities, renal function disorders tend to have problems with sleep-wake cycles. Individuals may be awake during the night, but then they're sleepy during the day. We may be having some flavor of that with this person where she's having decreased energy during the day and not being able to fall asleep at night. But one of the things that's piquing my interest here is the fact that there is this 10-pound weight loss in the background, right? That could be from underlying inflammatory disorders, or that could be from a hypermetabolic state. Hypermetabolic states can happen from things, for example, like thyroid disorders or toxins that people are taking in. So I think we're sort of being cued into the fact that there's confusion here. We can fall back on our altered mental status framework, but then also thinking about what are things that could cause confusion and maybe cause a syndrome of hyperarousal as well, because that is one thing that could make somebody have difficulty sleeping, and then also something that could make somebody potentially feel confused as well. But I'm curious, Sharmin, yeah, how are you putting these two together, or other things in the past medical history that are jumping out to you?
Oh, I love Jack. That was really, really brilliant. The other thing that is like just caught my eyes was the increased urinary frequency, and it kind of sounds, if I heard correctly, that she's also like drinking a lot of water too. So again, is this noise or is this signal? I just often like translate this increased frequency without the dysuria to polyuria, and just kind of thinking through causes of polyuria to just see if we can make any diagnostic progress. You know, the primary polydipsia is kind of a diagnosis of exclusion, but the other things that I think about are kind of things that you can like also pick up on labs, right? Like a polyuria, thinking about, is there any problem with sodium, as you mentioned, Jack, that is causing this confusion, whether it's like diabetes insipidus, that it will that can cause hypernatremia, or problem with glucose and glycosuria, or can it, or like problem, with the weight loss, everything else. If there's a hypercalcemia that can cause nephrogenic diabetes insipidus. So I think those are the labs that I would be interested in. I think with urinary frequency, we often think about making sure we rule out a UTI, especially an elderly person. But the fact that she has so much thirst and she's like, sounds like she's losing more water and in form of urination, it's just something that I'm curious to explore a little bit more as we go through the case. In terms of like her past medical history, nothing that jumps out to my. Sounds like a lot of the medications she's been taking for a while. Whenever there is an ARB on board, I always like think about the kidney, especially if I'm worried about someone getting dehydrated. So that's something to note about. And I'm curious to learn more from Rob.
All right, I'll give you up to the labs. So on exam, her temp is 98.6. Her blood pressure is 149/85. Her pulse is 73, and she's 97% on room air, so unremarkable. She's well appearing, She has notably dry mucous membranes, no cervical, axillary, or inguinal lymphadenopathy, no spinal tenderness. Her abdominal exam is completely benign, no rashes. The rest of the exam, unremarkable. For her labs, her white blood cell count is 3. Her hemoglobin is 9.6. Her platelets are 104. Her sodium is 137. Her potassium is 3.6. Her chloride is 101. Her bicarb is 27. Her BUN is 38. Her creatinine is 2.2. And we have a baseline creatinine for her of 0.69. Her glucose is 117. Her calcium is 14.1. Her albumin is 3.4. And I'll say we have data from 4 years prior where her calcium was 8.8 and her albumin was 4.1. Her magnesium is 1.8. Her phosphorus is 2.0. Her LFTs are unremarkable. And an A1C was obtained and was 6.3. And I'll stop there.
Rob, did you know hypercalcium is my favorite electrolyte?
Oh, really?
Yeah, it is. So thank you for this. I really appreciate it. I'll start with the exam and then pass the mic to Jack or go through the labs a little bit more. I think
Wait. Sorry to interrupt here. How are you going to give me the labs when hypercalcemia is your favorite thing to talk through?
you know, it's the holidays. It's a generous spirit of the holidays. We can talk through it together. How about that?
I you gave like a whole talk about hypercalcemia one time. So.
So I think like just starting off with the vitals, as Rob mentioned, again, pretty stable. Curious if she's been taking her medications or not. And I think in terms of exam findings, this is a personal, I mean, before we get to the labs, at this point, we don't have the labs, like making sure that good neuro exam as well to make sure, there's no locality to it is important. And the other thing that I would mention is, with people with hypercalcemia, constipation tends to be an issue sometimes, and that can also lead to more confusion. So that's something else to be able to kind of keep an eye on. In terms of the labs, the one thing that again notice, again, I'm not sure how chronic it is just all of her cell counts is a little bit low, right? So are we dealing with pancytopenia of some sort here? And whenever, think about pancytopenia, thinking about the issue more commonly is in the bone marrow. Are we dealing with some sort of bone marrow suppression, whether there's a malignancy, whether it's an infection, or any building block deficiencies that allows your bone marrow to make it? Again, that is probably a secondary problem that we should keep in mind because we have a bigger issue, which is the calcium. So severe hypercalcemia, again, kind of explains going back her polyuria, kind of thinking about the confusion. And so far, the AKI, so the hypercalcemia seems to be the primary problem we need to solve here. And personally, when I think about, and I think this is a lot of us, is that when we think about primary hypercalcemia, we often think whether this is PTH mediated or not PTH mediated. The three things I think about in terms of calcium are your PTH, and your vitamin D and calcitonin that allows for calcium homeostasis. So the first step is like to think about which is PTH mediated or PTH non-mediated. And a lot of the times I work in a hospital, so most commonly the issues I see are a PTH non-mediated hypercalcemia, so a lot of malignancies and other issues, versus out in the world, usually hyperparathyroid issues are quite common. So that is a good lab to get right off the bat, and sometimes it takes a while to come back. So then we still need to make some diagnostic process. And for that, I pass the mic to Jack.
Oh, thanks so much, Sharmin. All right, so our task now that we have identified hypercalcemia is twofold. One is to ask ourselves, are some of the other metabolic abnormalities that we see attributable to the hypercalcemia, for example, the acute kidney injury? And then the second thing is making progress in terms of the underlying etiology of this person's hypercalcemia. So I think for the first one, I think it's worth having in the back of our minds an understanding of what calcium does to somebody's underlying metabolic function, and particularly their renal function, right? There are really three mechanisms by which hypercalcemia can lead to renal insufficiency. The first is that hypercalcemia can cause some component of volume depletion. As Sharmin talked us through at the beginning, right, there's some polyuria here that we're seeing, and that polyuria is usually driven by the high urine load that the individual ends up making to hopefully help to excrete the extra calcium within their bloodstream. So there can be hypovolemia is one way by which hypercalcemia can cause renal insufficiency. The second one is that the high calcium levels can lead to some component of direct tubular damage. And then the third one is that calcium mediates some component of vasoconstriction within the blood vessels that feed into and come away from the kidney. And that vasoconstriction can lead to a decreased GFR as well, right? So the hypercalcemia is probably playing a role in driving this individual's acute kidney injury. That becomes important because as we think about possible causes of hypercalcemia, as Sharmin mentioned, some of the more common ones that we see in a hospitalized patient are hypercalcemia of malignancy, issues related to hyperparathyroidism, and then a third one that comes up quite often is the milk alkali syndrome. And the milk alkali syndrome is unique amongst the causes of hypercalcemia because it tends to cause a metabolic alkalosis, right? In most cases of hypercalcemia, for the reasons that we mentioned, people will tend to have a metabolic acidosis. The renal insufficiency that develops leads to problems handling bicarb, and that usually leads to a metabolic acidosis. But when we're ingesting large amounts of calcium and large amounts of alkali, like in the milk alkali syndrome, individuals tend to develop a metabolic alkalosis. Now, her bicarb is 27, roughly normal, maybe a little bit on the higher end. So this may be a cue to go back and ask her, hey, by the way, have you been experiencing some dyspepsia? Has there potentially been some ingestion of Tums recently? Because that can sometimes give us a clue here. The other, so that's one metabolic abnormality to always be sure that you look for in the individual who has hypercalcemia. When you see the high calcium, look at the bicarb. And the other thing that I want you all to look at when you see a high calcium is to look at the phosphorus level. Because making progress on understanding what the cause of somebody's hypercalcemia is, firstly relates to understanding what the parathyroid status in the body is, right? Hypercalcemia can be related to parathyroid-mediated causes, whether that's primary hyperparathyroidism, like Sharmin mentioned, or tertiary hyperparathyroidism, which tends to develop not in individuals like this, but somebody who has end-stage renal disease. PTH-independent causes tend to include things related to malignancy, right? So that could be something like multiple myeloma, where individuals have lytic bone lesions, or it could be related to high levels of vitamin D circulating in the body, which could happen from high vitamin D intake or endogenous production of vitamin D in granulomatous disorders, right? Where the granulomas possess 1-alpha hydroxylase, which activates vitamin D, and then that activated vitamin D leads to high levels of vitamin D in the body and ultimately the development of hypercalcemia. So those PTH-independent causes, hypercalcemia of malignancy or excess vitamin D from taking too much vitamin D in or making too much vitamin D in the body, can help us can give us sort of a roadmap of where to go from here. But understanding the PTH status is a key role. We can definitively understand the PTH status by checking a PTH level, which hopefully we will be able to get soon. But the phosphorus can also give us a clue to that. Because in addition to PTH standing for parathyroid hormone, it also stands for phosphate tracking hormone. When parathyroid levels are high, the phosphate will tend to drift down. And in this individual, her phosphorus level is on the lower end of normal. And that's interesting here, particularly in the context of her renal insufficiency. Usually when people have an acute kidney injury, the phosphorus levels tend to slowly rise. but hers has drifted down. Now, there's many hypotheses for that. One could be she's not taking in much food because she's been confused and feeling crummy. But the other is that potentially she has high levels of PTH in the body. That could be endogenous PTH from something like primary hyperparathyroidism, ectopic production of PTH, which can happen in some parathyroid cancers, or the paraneoplastic phenomenon of PTH-related peptide production, which can give somebody a PTH-like picture in the body, high calcium, low phosphorus, but normal PTH levels. And then we have to check the PTH-RP level to fully confirm that. So we have some clues here. Maybe there's milk alkali syndrome, but it doesn't seem like it's clear. Maybe there's some bone marrow infiltrative process like multiple myeloma driving this, or maybe there's another paraneoplastic phenomenon leading to pancytopenia, like a disseminated cancer that happens to be leading to the production of PTH-RP levels as well. So I think that would be the place to go from here. Let's look at the PTH levels, maybe check a vitamin D level, and then whatever else Rob may have in store for us.
Dude, that was beautiful. Loved it. I love thinking about the alkalosis and using FOS to make some progress. And I loved how you were overlapping kind of the pancytopenia and the hypercalcemia and see what the overlaps are. So your infiltrative, like lymphomas, multiple myelomas, your infections that can do it. So that was awesome. I think in terms of a management right here, you know, we having a person who has symptomatic hypercalcemia. So definitely this person that you want to treat as you're trying to figure out what you're doing, you know, fluids. Be careful with someone who have renal insufficiency. You might need some help with your friend Lasix if you're volume overloading. But again, you want to make sure, as Jack mentioned, this is a person who is probably hypovolemic and you don't want those crystals to form. And I personally love calcitonin, at least like giving a dose and seeing if the hypercalcemia is responsive to that. So it kind of brings down, again, it doesn't sustain, but however, it buys you some time. And then to think about bisphosphonates as well. People, again, with AKI, it's a little rough. So you oftentimes like want to ask your endocrinologist, a friend, which you have Dr. Weber, whether they would recommend bisphosphonate at this time or hold up until the kidney is getting a little bit better. Some of it is also depends on the etiology of it, but this is someone that I would like start the fluids and also give the calcitonin and while the other workup is coming back.
Beautiful. I agree with all that. So I'll give you the data you requested, and the management was as you said. So PTH was 12, and in our lab, the normal range is 18 to 90, so that was low. PTH-RP was 1.4. Anything less than 4 is normal. 25 hydroxy vitamin D was 34, and the normal range is 20 to 50. 125 vitamin D was 103, and the normal range is 20 to 79. LDH was sent and was 198, which is normal. An SPEP was sent and was normal. A smear was done and it showed rare atypical monocytes. An ACE level was sent and it was 81. And in our lab, it goes 9 to 67. An HIV was negative. An AM cortisol was 14, which is normal. A TSH was 2.3, which is normal. And a B12 was 1,000. And then simultaneous, in parallel with this workup, she received, as you said, IV fluids, calcitonin. Her kidney recovered and she was able to receive a dose of zoledronic acid. And then over the next few days, her calcium improved. And I'll stop there.
All right. So it sounds like what we have here is we have slightly low PTH levels, normal PTH-RP, a normal 25 vitamin D, but a high 125 vitamin D. Maybe what I'll do right now is I'll just take over the screen for a brief second and just kind of localize us in the map of hypercalcemia, and then turn it over to you, Sharmin, to take us through kind of where we want to go or how we want to discover more about where we are in this map. But let me just pull this up here. Can everybody see this okay? So as we said, this is one way to think about hypercalcemia, an overview of it. We have PTH dependent and PTH independent causes. We know that we're down here in the PTH independent causes for a couple reasons. One, the PTH level was not only normal, it was actually low, which is what we should expect to see when there's a PTH independent process happening. The high calcium from a PTH independent process should drive down the PTH levels to be below the normal range. And within the PTH independent causes, we said we can have hypercalcemia of malignancy, hypercalcemia related to high 125 vitamin D, and the milk alkali syndrome. Now, we know that I shouldn't say we know, we don't think that we're dealing with the milk alkali syndrome, and we suspect that we're here in the high 125 vitamin D category. And there are three things that can drive that, right? One can be high intake of vitamin D. Another can be granulomatous disorders. And sometimes vitamin D or 125 vitamin D is a product of humoral factors that are released in hypercalcemia of malignancy. So PTHRP or tumors that are leading to the extra production of 125 vitamin D can be a part of hypercalcemia of malignancy, right? Our 125 vitamin D level is high here, so we now have to figure out which of these three causes is it from: a granulomatous disorder, high intake, or potentially a tumor that is driving the ectopic production of vitamin D. Sometimes those tumors are cancers that have granulomas in them. The granulomas, again, have 125 have alpha hydroxylase, the enzyme that leads to the conversion of 25 to 125 vitamin D. But interestingly, this person's 25 vitamin D level is also quite high, despite the fact that her body is converting a lot of that 25 vitamin D to 125. So I will stop there and pass it over to Sharmin, but this is sort of where the center of gravity for us is now, in the middle of here, answering the question of why the 125 vitamin D is so high in this case.
This is so wonderful. This is my favorite cause of hypercalcemia, granulomatous diseases. Wow, this really feels like a Christmas gift. Thank you, Rob. In terms of like the intake, I think is a good point. I often associate that with elevated hydroxy as well. So when both of them are elevated, I think more of intake. Rob, please correct me if I'm wrong in that. So I think for me, the highest suspicion would be granulomatous disease at this point. And when I think about the granulomatous diseases, one time as a separate medication called calcium. Thank you. So thinking about increased intake and thinking about the granulomatous disease, especially in the setting of the pancytopenia, I wonder if as part of our answers will lie in the bone marrow. So this is someone that I would consider thinking about bone marrow biopsy, whether that would give us more information, and kind of looking back at her smear that she has some atypical finding. I mean, things about granulomatous disease, weight loss, the cancer that is most forefront of my mind is a lymphoma. So that's where I think perhaps it's going to be the most helpful in terms of a diagnostic process, because while you can evaluate for cancer, you can also think about a lot of the infection that goes to the bone marrow and cause granulomatous disease. With infections, again, we're not really getting a flavor. However, they tend to be more indolent, right? Your endemic mycoses, your bacterial, your mycobacterium, the ELAs that can do this as well. And if she has the right risk factors, thinking about leishmaniasis and schisto. Autoimmune diseases can do it. Again, I think for her, I have a little bit of a lower suspicion, but like sarcoid can do anything. And the cancer lymphoma we've talked about. The rarer causes of that are like foreign body, the second thing I did when I looked at her medication, like allopurinol is associated with this. She's not taking that. And some like immune dysfunctions. But the other thing that caught my eyes, again, I don't know if this is related. I don't know much about the silver that she's taking. I don't know what it causes. I don't know what the side effects of. That's something that I would Google is her med list as well, to make sure there's nothing that is would cause any issues there. I think so. In terms of like next steps, as you mentioned, thinking about the malignancies and doing a little more of an infectious workup would be where I'm headed. Any other thoughts, Jack?
No, I think you summarized that absolutely perfectly. I think the elevated ACE level is an interesting thing to contend with here, right? Because we are like common association with that is sarcoid. It ACE levels, at least the way that I've been taught to use them, and is to treat them almost like a tumor marker. So in the same way that certain tumor markers are helpful for monitoring a disease once the diagnosis of cancer has been established, ACE levels can also be helpful for monitoring sarcoid activity once the diagnosis has been established. But in this case here, I'm not sure what to make of it. Like, it probably increases the probability of sarcoid a little bit, but we have to interpret that in the background of no other prominent findings suggestive of sarcoid other than a strong suggestion of a granulomatous disorder, like you mentioned, Sharmin. And so I think there's what the reflexive pull to say that this must be sarcoid because the ACE level is high. But I think that that association of the ACE level being high is more helpful when someone is known to have sarcoid rather than when we're trying to discover them having sarcoid or not. So other than that, I am 1,000% with you in terms of the possible granulomatous diseases that are at play here.
I completely agree with everything. So we were where you are at the time. So what happened was when her calcium improved, her mental status cleared up, and we got some additional history. And she confirmed no calcium, no exogenous calcium intake, no Tums. In fact, she's a little lactose intolerant, so her diet is low in dairy overall. She's had no history of TB that she knows of. No one in her home has had TB. She's had no travel outside of Northern California in decades. She actually has had surgery. She had breast implants in the 1970s back in Korea. And when she came to America, she was recommended to change those from silicone to saline. So she had a second surgery in the 1990s. She's had no exposure to cats. She has a pet dog. She's had no preceding diarrheal illnesses. She had no preceding pneumonia, and she has no new rashes. We also have some additional imaging, and a bone marrow biopsy was attempted, but was unsuccessful. There wasn't enough material. Flow cytometry was done because of her smear, and there were increased myeloid blasts and a rare monoclonal B cell population. CT scan showed bilateral axillary and retroperitoneal, as well as left inguinal lymphadenopathy. An attempt was made to do an ultrasound guided lymph node biopsy of her axilla, but there were actually too many granulomas. It appeared, I looked at the imaging, it appeared like a starry night sky, so you couldn't actually identify the lymph nodes to biopsy. And so a surgical lymph node biopsy was obtained, and the result of that will give the final diagnosis.
Wow, what a journey. So I think like putting it all together, this is 75-year-old who is coming in with like altered mental status, polyuria, who ended up having a pancytopenia and hypercalcemia. And now with like further workup, I'm glad, interesting that the bone marrow didn't have enough material. She has some myeloid blasts, so that makes me concerned for a lymphoma. And I think again, like a lymphoma is your diagnosis, your no misdiagnosis here. So getting that surgical, and it sounds like a granulomatous process. So that's where, and then like kind of the other thing would be like sarcoid, I feel, as you mentioned, Jack. But again, for me, it's like lymphoma until proven otherwise. How are you thinking about it?
I'm with you. I think looking at the age of this individual and the absence of other compelling exposures or reasons for her to have an infectious cause of a granulomatous disease, I think the weight is most heavily within the malignant category. There is an interesting sort of overlap between sarcoid and lymphomas. Many lymphomas can cause a sarcoid-like reaction, which could explain the elevated ACE level, the diffuse granulomatous processes. It tends to be a lymph node predominant sarcoid-like reaction. And so I think that is something that's at play here. But the converse is also true. Individuals who have sarcoid have a slightly increased risk of developing lymphoma. The caveat there is that it tends to be within a couple years of the diagnosis of sarcoid, the lymphoma comes out, or within a couple years of the diagnosis of lymphoma, we see the sarcoid-like reaction. So I think given the fact that she's 75, the base rate of disease would favor cancer over an emerging autoimmune disease. And I think most likely I'm with you, the lymphoma is there. In terms of the lymphomas that can do it, there's a huge variety. It tends to be Hodgkin's lymphoma over non-Hodgkin's lymphoma, but her being 75 years old, she would be more likely to have a non-Hodgkin's lymphoma than a Hodgkin's lymphoma. And it's important to know that really any of the lymphomas can do it. So Hodgkin's have a slightly increased predilection. You can see it with non-Hodgkin's lymphoma. And then there are some very aggressive T-cell lymphomas that have a tendency to do it, particularly if they come with mycosis fungoides, which she doesn't seem to have here. And so I think we're really looking at sort of the base rate of disease and the fact that she seems to have had a relatively indolent disease process, right? There's a little bit of weight loss here, but we're not seeing really aggressive lymphadenopathy developing. She does have sort of a variety of different lymph node chains that are involved, but we're not seeing hugely aggressive other paraneoplastic phenomenon, right? We're not seeing HLH developing. So maybe some of the aggressive lymphomas become a little bit less likely, but certainly DLBCL or the bad T-cell lymphomas like angioimmunoblastic T-cell lymphoma are at play. I think maybe some of the more indolent ones, right, follicular lymphoma and some of the other indolent lymphomas may be more likely because of the fact that she seems to have had a somewhat indolent disease course so far. But again, with the limited history, like Rob mentioned, I think it's hard to really say. But I think the take homes here is that when you see hypercalcemia and the possibility of lymphoma, Hodgkin's is a little bit more likely, but I think epidemiology plays a stronger role here. So I think a non-Hodgkin seems more likely. And then we're just trying to decide, is this an aggressive disease? Let's think about the aggressive lymphomas. Is this an indolent disease? Let's think about the indolent lymphomas.
100%. So I was with both of you. I was like, this is lymphoma. We know steroids are a good treatment for 125 mediated, but we didn't want to obscure the diagnosis. So we held off on steroids until we could get this biopsy. Here's what the biopsy said. What appear as giant lymph nodes on imaging are actually small, benign lymph nodes surrounded by fibrous histiocytic granulomas containing extracellular pools of an inorganic substance that optically appears to be silicone. The most likely diagnosis is granulomas from silicone leak. So we went back to the patient and we were like, tell us more about your breast implants. And she was like, oh yeah, I got them replaced because they were leaking back in the 90s. So.
Wow, foreign body, mind blown. Wow.
This is such an awesome case. And I think what is so cool about this case is that the way that you all arrived at this diagnosis, right? Like, I think it would be really interesting to know how to handle this, right? If we were like, oh, we really think that this is from the breast implants before the excisional lymph node biopsy has been done. I think we reflect so often on how where we arrive in terms of the final diagnosis matters, but also the path that we take there really matters. And I think settling on foreign body related granulomatous disease before lymphoma is definitively excluded might seem like accurate reasoning retrospectively, but prospectively, right, we risk potentially missing something like an underlying lymphoma. So Rob, I think not only is this case incredibly educational because of where we arrived, but also seeing the path that you all take to arrive at that diagnosis, I think is such an important lesson. We have to falsify the more probable hypotheses before we definitively prove the less probable hypothesis. So formally excluding lymphoma here with the excisional lymph node biopsy, I think is a really, really important diagnostic take home here. So thank you for bringing this.
Yeah, wow, what a case. Thank you so much, Rob. Just out of curiosity, did he have any thoughts about the myeloid blasts that she had? I know this explains the hypercalcemia, but just curious what their thoughts were and what did you guys do for treatment?
We don't know yet. So this is kind of new data that we just got in the last couple of weeks. One hypothesis is that this is just a reaction to the silicone. One question I had though is like, why is this happening now when the leak happened 30 years ago? And I've looked into case reports, and there does seem to be a latent phase depending on the case reports. And but there's also shorter ones where you get silicone injected right into the body parts and you get a reaction right away. So I wonder if it has to do with the amount of silicone and the purity of the silicone, but that's like pure speculation. And I did want to plug this great paper that was super helpful. It's a 2005 paper called Clinical Review, Rare Causes of Hypercalcemia. And I think if you're stumped with a case of hypercalcemia, looking at this paper will help you. Yeah, I'll put it in the chat.
Amazing. And did you also do steroids?
Oh, I'm sorry. You know, she did pretty well with zoledronic acid for 10 months before she became hypercalcemic again. So given her age, we were thinking about proceeding with just zoledronic acid as needed and spare her chronic steroids. But yeah, we're still figuring it out.
Oh, this is awesome. I love zoledronic acid when it works, you know, it's great.
Rob, is there any way to get like? Did you come across anything about ways to like take it out, or ways to dissolve, or like even ways to, or once it's spread, it's just sort of like we have to deal with the sort of diffuse spread of this?
Well, at this point, it's been removed or surgically removed, and we're left with this inorganic material that's been scattered among her axilla. Like, I wish I could show you, I wish I had handy the images, but literally like tiny granulomas all over the place. So I think to surgically remove that would be quite challenging.
Wow, so much great learning. I'm so happy right now. This was great. Thank you so much, Rob. I really appreciate it.
Shout out to Austin, who used the PTH to chloride ratio in the chat, which I also used. And before the data came back, I was like, oh, it's PTH mediated for sure. But I guess that goes to show that that ratio is not foolproof, that chloride to phosphate ratio.
Yeah. Yeah, I feel like so much of medicine is like managing uncertainty and like making diagnostic progress, and then like stents that we do, which is pretty cool. All right, Hansu, we're ready for you.
Thank you so much for this great case, Dr. Robert, and thank you, Sharmin and Jack, for the great discussion. So we had a 75-year-old female presented with confusion and insomnia, and confusion is a common chief complaint that we see in the clinical problem-solving space frequently, and we use the AMS framework, which is the NMIST, which is coined in the NMIST mnemonic for us. But this patient didn't only have confusion, she also had insomnia, which was very interesting because when we layer confusion and insomnia, we started thinking, does the patient have decreased arousal during the day and decreased energy, which is leading to not being able to sleep at night? And is that how we tie the confusion and insomnia together? And the patient also had urinary frequency and polyuria, and we started thinking about the causes of urinary frequency and polyuria, which are primary polydipsia or diabetes insipidus, which could be resulting in hyponatremia, causing confusion, or this could be nephrogenic diabetes insipidus secondary to hypercalcemia, which could also lead to fatigue and confusion. This patient's vitals were stable, and there was no focality in the neuro exam, and we also saw that there was hypercalcemia in the labs, which could be leading to confusion, as we said before. And in the labs, we also saw that all cell counts were low, and we thought, is there bone marrow suppression secondary to malignancy or infection, or is there a lack of building blocks of the cell lines? And so after getting the vitals and all the labs, we decided that our main problem here was hypercalcemia. And that's the problem we need to solve. And whenever we have hypercalcemia, we also have to keep an eye on other metabolic abnormalities that hypercalcemia is keeping company, which one of them being acute kidney injury. Hypercalcemia can cause renal insufficiency in 3 ways. One of them is volume depletion, and the second one is direct tubular damage, and the third one is decreased GFR secondary to vasoconstriction of the vessels that are feeding into the kidney. And we also have to think about the underlying etiologies that are leading to hypercalcemia, and the branching point that we use here is whether hypercalcemia is PTH mediated or non-PTH mediated. And PTH non-mediated causes are, we usually see those in the hospital, and the causes for the PTH non-mediated hypercalcemia are malignancy, such as multiple myeloma causing osteolysis and hypercalcemia, or autoimmune issues. And high vitamin D levels can also cause PTH non-mediated hypercalcemia. And in that category, we have granulomatous disorders, lymphomas, and then there's milk alkali syndrome. And when patients have high calcium, we have to look at the bicarb levels. Because this could be resulting from the milk alkali syndrome, and it can lead to metabolic alkalosis. In this patient, bicarb levels were on the higher end, so that led us to question whether the patient was taking Tums. And we also have to look at the phosphorus levels whenever we have hypercalcemia. And in this patient, it was in the lower end of normal, so we started thinking whether this could be caused by dietary insufficiency or high PTH. And high PTH could be caused by endogenous secretion or ectopic secretion of PTH, or tertiary hyperparathyroidism. Since this patient had hypercalcemia and polyuria, we were suspicious that the patient might be having volume depletion. So we should also think about management here with fluids and calcitonin. When we got the further labs and found out that the patient had high 125 OH vitamin D levels, we started thinking about the potential causes for that. And in that category, we have high intake of vitamin D, granulomatous disorders, humoral factors in hypercalcemia of malignancy that are causing an increase in 125 OH vitamin D or PTHRP secreting malignancies. And when we thought about further, like what could be those conditions that could be causing the increase in the vitamin D levels, in that we have sarcoid, which also could be causing elevated ACE levels that we saw in this patient, which is a good parameter for monitoring the disease activity, and granulomatous diseases could also be at play here. We also have lymphomas and foreign body reactions in that category. So after we got the flow cytometry and we saw myeloid blasts and axillary and inguinal lymphadenopathy in this patient, we started thinking about the do not miss diagnoses, such as lymphoma. And since sarcoid lymphomas can have lymph node predominant sarcoid-like reaction, it was like on top of our differential list. And we started thinking what kind of malignancies could be possible in this age group, and non-Hodgkin lymphomas were on top of our differential. And lymph node biopsy later showed giant lymph nodes were not actually giant lymph nodes. They were small and benign lymph nodes, and there were presence of fibrous histiocytic granulomas with inorganic substance. And it turned out that with further digging into the patient's past medical history, the patient got breast implants, and it was leaking the silicone within the implants, and that was causing the foreign body reaction. And the myeloid blast on flow cytometry could be explained as a reaction to the silicone leakage. And why is this happening now, since this patient's silicone implants leakage happened 30 years ago? And we found out from Dr. Robert that there were reports related to latent cases. So it was a very, very interesting case. Thank you so much.
That was brilliant recap of teaching points. Thank you so much, Tansu. Really, really appreciate it. Rob, sorry, did you want to say something?
No.
Oh, this was such an awesome case. Thank you so much for presenting. I'm so glad the patient is doing well on bisphosphonate therapy. Thanks all for joining us. And if this doesn't prove that calcium is cooler than sodium, nothing else will. I rest my case. Oh, no comeback, Jack? All right, I'll take it.
We can let calcium have its spotlight for 52 minutes. That's okay.
All right, thanks all. We'll see you tomorrow. Bye.
Right?